participate by contributions as building blocks towards harmony and peace. Grant that we interact with one another, we recognize the fact that all our learning activities should be accomplished for one greater glory. Grant that we recognize you in each of us as we live for home. We pray that you keep us safe from harm and illnesses, and we would be able to apply correctly what we have learned today. All this we ask in Jesus' name. Amen. Good evening, everyone. Uh, Good evening, everyone. Welcome to PSD Select, second episode of Diabetes and Alpha Cells. Uh, this is Dr. Marcy Cruz, Treasurer of PSD. I will be your host and moderator for tonight's activity. We have in your slide, we plus the PSD vision and mission. And tonight, we have you could see in your screen the program. Before we start, we have the Kwentuhan Tayo with Dr. Elwin Fernando, our PSD President. Kuya?
Mag-share na ako ng aking slide, ha?
Okay po.
Good. Yan na. Game tayo. Nagkukwentuhan na naman tayo. Nag-i-enjoy sana tayong lahat sa buong portions, sa entire portion every Saturday for a few Saturdays habang pinag-uusapan natin ang Alpha Cell dito sa PSD Select Lecture Series 2. Napasalamat ako at ang sponsor naman natin ngayon ay Warwag Pharma. Thank you, Mike. Siya ang representative ng Warwag with us tonight. Meron silang bagong gamot na dinadala para sa atin. Pag-uusapan natin mamaya yung thioctic acid kasama si Doktora Agra. Pero kung tutuloy natin ang kwentuhan natin tungkol sa Alpha Cell na sinimulan natin last week ng history, no? History ng Alpha Cell. At binigyan tayo ng napakagandang lecture ni Dr. Ernie Ang on the physiology tsaka ng alpha cell, no? Tsaka ng glucagon. Ganda ng lecture ni Sir. Pwede nyo balikan yun, ha? Para gusto nyo maintindihan lalo yung lecture. Pwede nyo ulitin yun. Nandito sa site natin yung lecture ni Dr. Ang. You can repeat that anytime. You can repeat it 2 times, 3 times, 4 times hanggang sa ma-master nyo. No? Kaya dito sa portion natin ngayon, sa maikling kwentuhan, pag-usapan naman natin yung konti yung embryology nung islets at saka nung alpha cell. Konti lang. Para lang magkaroon tayo ng konting idea, pero kasi itong development ng alpha cell at saka ng islets, hindi magtutuloy yan kung walang walang microscope eh. At yung microscope nagsimula yan sa development ng lens. At ang unang lens na na-discover daw yung Nimrod lens at na-date nila na 7th century BC. Yung lens na yan kamukha nung salamin natin, lens. Hindi nila alam talaga kung saan ginagamit yan nung araw Pero na-date nila nung 7th century BC. Ang hula nila, ginagamit yan to start a fire. Yun ginagamit yung old lens. Very crude nga Pero yung refinement nung lens, dumating lang nung mga years 1300s. Kasi sa mga paintings ng church, na-document yung isang cardinal. May suot-suot na spectacle. May suot-suot na salamin. Kaya by that time, By that time, maaaring na perfect na nila yung ano yung paggawa ng lens at nagkakagawa na sila ng eyeglasses. 1352 yun. But it was during the 1800s nung ma-develop at ma-invent yung iba't ibang klaseng microscopes. Yung mga microscopes yan, nagaganda, no? Mga mga hobbyist lang ang nagkakaroon ng microscope nung araw eh. And many of them are doctors who love to study the tissues of the body. Hindi lang doctors ha, pati ibang mga ibang mga anatomists, mga veterinarians, pinag-aaralan nila yung mga tissues ng iba't ibang living organisms. And they write it down. Yan nga yung ginamit ni Paul Langerhans nung ma-discover niya yung yung islets na may iba-ibang palang cells maliban dun sa acinar cells sa pancreatic tissue. And that was during the 1800. Pag sinabing 18th century, 1700 yun eh. Ito, 1900 pag sinabing, yung, pag sinabing 18th century, ano yan? Tama, 1700s yan. Pero sabi nyo, 1800 something yan eh. No? At that time, doon din nag-evolve or biglang lumago yung study of embryology. Before the advent of the microscope, alam nilang nanggagaling sa punla, yung baby, yung punla, yung sperm. At ang una nilang isip, sa bawat isang sperm, may isang tiny organism. Yung buong organism nandun na. May iba't ibang organs na, may limbs na. Kaya ang ganda ng picture nila dito. May may baby doon sa loob ng sperm at yun ang lalaki sa womb. Until na nakita nila, little by little, nagsimula pala yan sa isang cell lang at yung isang cell na yun, nagdi-divide, dumadami. And it was a long and tedious process. Mabagal yan eh. Pero napakagandang pag-usapan at pagkwentuhan. No? Ngayong 1827, si Carl Ernst Bohn, na-describe niya yung blastula stage at saka yung notochord sa mammalian ovum. Pagkatapos later on, just after a year, napakita niya yan sa human ovum. Kaya hindi pala isang buong organism na kaagad ang isang na dumatating pagpasok sa womb. Ano pala yung magsisimula sa isang cell at mag-divide into many cells. Si Heinz Christian Pander, the year after, na makita ni Carl yung human ovum, dinescribe naman niya yung 3 germ layers, Kaya sabi niya, yung sisimula yan, it's one cell, nagdi-divide into 2, 4, 8, until they form different layers. Importante yan, di ba? Yung may ectoderm, may mesoderm, saka may ectoderm. 3 layers yan. Alam na alam niyo lahat kasi lahat kayo mayroong embryology, no? And it was also after 50 years pa pala bago na pakita ni Oscar Hertwig yung talagang process of fertilization. Kaya dahan-dahan na napapakita yan dahil sa development ng mga tools so that we can see what is really happening. No? And then, later on, na-describe nila yung talagang process ng embryology. Yung palang sa mesoderm, doon ang gagaling yung development ng pancreas. At yung pancreas, nagsisimula, may dorsal at saka may ventral buds. At yung mga buds na yan, umiikot, nagsasama yan. Lumalaki muna from A, picture A, buds pa lang siya. Itong brown ang liver eh. Gallbladder, yung green eh. Yan mga rudiments yan eh. Later on, pag nag-progress na yung fetus, lumaki yung dorsal at saka yung ventral buds, iikot yan until they fuse into one organ, and that is the pancreas sa letter C. And finally, magre-rest siya dun sa mag-develop part of the gastrointestinal tract sa tabi ng duodenum, sa tabi ng gallbladder. At sa itaas naman niya, nandun yung malaking-malaking liver. Liver. Importante yan eh. Kasi along the way, as it goes around, it brings with it the blood vessels, iba't ibang mga blood vessels na natatangay niya. Ano ba yung mga blood vessels na yan? Nandyan yung splenic artery, splenic vein, superior mesenteric artery at vein. At makikita nyo dito yung blood supply ng pancreas. Bigyan nga natin isa pang mas magandang picture yan. Ano? Kita nyo ngayon dito, mas close-up view. No? Yung pancreas, no? Ang blood supply niya nasa superior mesenteric artery, splenic artery, pagkatapos pagka na-bathe na sa blood, na-provide na ng food, ng blood, yung pancreas, magde-drain yan doon sa lower mesenteric vein, pancreatic lower mesenteric vein, superior mesenteric vein. Saan siya pupunta? Sa portal vein. Ibig sabihin, lahat ng lahat ng endocrine secretions ng pancreas ang punta sa portal vein. Eh saan naman ang punta ng portal vein? Sa liver. Kaya di ba yung pinag-aralan natin ang insulin, saan ang first effect niya? Sa liver. Kasi pag ginawa siya ng pancreatic beta cells, nag-drain yan sa veins, sa pancreatic veins, ang tuloy niyan sa portal vein, tuloy sa liver. Kaso hindi lang insulin, lahat ng nilalabas na hormone ng pancreatic islets of Langerhans. And that includes also glucagon. Glucagon. Ang ganda ng lecture ni Dr. Ernie Ang last week. Paulit-ulit kong pinapanood yun. Pero kita nyo, tama siya. Talagang unang effect ng lahat ng hormones ng pancreas, no? Especially insulin at saka glucagon sa liver. Kita nyo, sa liver ang punta. From pancreas to liver. At yan, ang ginawa ng Panginoon, hindi mo magagaya yan. Kaya kahit na anong klase ng insulin injection ang ibigay natin, hindi niya mape-perfect yung ginawa ng Panginoon. First pass liver. Ma-approximate yun. Pero yung perfect, hindi siguro, no? By the time before the Second World War, 1993, nag-improve pa yung microscope eh. Naging electron microscope. Ibig sabihin, hindi na siya nakakakita lang ng mga cells. Nakakakita na siya ng mga molecules. Mas maliliit na ang nakikita. Nung na-develop yung electron microscope, una sa Russia yan eh. 1933 at tuloy-tuloy nag-evolve yan. Ngayon, lahat yata ng countries meron ng electron microscope. At ang ganda-ganda na ng mga bagong mga electron microscope, mas madali nang gamitin. Pero syempre, yung gumagamit yan sa research ginagamit yan. And because of the electron microscope, a lot of things has been discovered. May pinakita si Dr. Ernie ang last time na picture ng cell ng pancreatic islet, no, of a rat. Ito rat pancreas yan eh. Ito. Yung one, sa square one, in-stain nila for insulin. Kaya lahat ng nakikita nyo ngayong stained portion ay beta cells. Kasi insulin yung in-stain niya. Kaya ganyan pala sa rat cells, sa rat islets. Ngayon, pag ang in-stain naman ay glucagon, ito naman na makikita sa number 2. Sa number 2 naman, makikita nyo na nasa periphery ng islet yung mga alpha cells. Alpha cells. At yan may reason na sinabi si Dr. Ernie Anglas ano kung bakit ganyan arrangement yan eh. Every time nagagawa ng insulin ang beta cell, pag lumabas siya, masasalo yung insulin niya na yan ng alpha cell. Kasi ang major effect ng insulin is to, to suppress the secretion of glucagon sa alpha cell. Napaka-importante yun, ano? Ang daming insulin from the inside. Pagka lumabas siya, dadaan siya sa alpha cell bago makalabas ng islet. That way, every time insulin is produced, glucagon is suppressed. Suppressed. Ito naman ang in-stain naman dito somatostatin. Kaya kukunti lang pero meron pa rin. Dito yung PP cell naman. In-stain nila sa number 4. But you can see, because of the advent of technology, pwede mong makita yung gusto mo talagang makita. Kailan kaya natin magagawa sa Pilipinas yan, But this was way back 1976, 76. This is 40 years ago. 40 years ago, dapat kaya-kaya natin gawin itong mga ganyang klase staining ngayon. Sinabi rin ni Dr. Ernie Ang last time na unlike the rat pancreatic islets na well arranged, nasa periphery yung alpha cell at nasa gitna naman yung beta cell, sa humans unique ang arrangement. Parang halong-halo siya, ibang klase, halong-halo. Meron kayang ibig sabihin nun? Nalaman din nila kung ano nangyayari diyan, na-discover nila at nakagawa sila ng magandang theory. And this was published 10 years ago, 2010, ni Bosco and Armanet. At ang ginawa nila, pinag-aralan nila yung mga islet cells using itong mga technology. Ni-slice nila yung buong islet at tinitingnan nila yung distribution ng iba't ibang cells throughout the islet cell, the islets of Langerhans. Makikita nyo, from slice 1, 2, 3, sinislice nila yung buong cell At yung cell pala, itong buong islet. At itong islet na ito pala, hindi flat. Nakamukha nung iniisip natin pag nakakita tayo ng island sa South Pacific. It's not a flat thing, It's round. It's a ball. It's a ball of cells. Na pagka kinat mo at certain areas, tuloy-tuloy ang pagkat hanggang makarating ka sa gitna, unang cut mo, siyempre yung balat pa, yung towards the periphery pa lang yan. Ang tawag din yung mantle, yung cover niya. Tapos dadating ka sa loob ang tawag diyan core, May mga specific arrangements pala siya, hindi siya basta-basta at random, Pero paano nilang inanalyze yan, Inanalyze nila sa pamamagitan na pag na ginamitan nila ng computer, tiningnan nila kung ano ang magkakatabing cells. Ang katabi ba ng beta cell alpha cell? O ang katabi ng alpha cell alpha cell din? O ang katabi ng beta cell beta cell din? Kaya binilang nila lahat ng beta cells na may katabing alpha cells, lahat ng alpha cells na alpha cell lang ang katabi, at lahat ng beta cells na beta cell lang ang katabi. At nakita nila na ang 80%, 8 out of 10, magkatabi ang beta at saka alpha cell. Importante yun, ha? Importante yung magkatabi sila. At sa pagdodrawing nila, na-explain nila kung anong ibig sabihin ng juxtaposition. Yun ang sinasabi ni Dr. Ann last time. Di ba? Juxtaposition. Ibig sabihin, naiipit yung green na alpha cell ng mga beta cells. Lahat ng alpha cells may katabing beta cells. Yan ang sa human islets of Langerhans. Na ini-stress niya yung fact, yung katotohanan na importante na laman ng alpha cell na yung beta cell ay gumagawa ng isang secretion, which is insulin. So every time insulin is produced, no, malalaman ng alpha cell yan. Whether rat or human, no, dadaan yung ma-feel ng alpha cell na gumagawa ng insulin ng beta cell, at ang normal response ay ma-inhibit ang secretion ng glucagon. So that is how it works, no? Ngayon, na theorize nila nasa development daw, kaya yung unang tingin mukhang halo-halo siya, no? Sa development daw ng alpha cell at saka beta cells at yung iba pang cells, bumalik naman doon sa layer theory. Yung nauna sa embryology, germ layer theory. Ito yung layer theory na isang layer ng beta cells sa itaas, isang layer ng beta cells sa ibaba, pagkatapos isang malaking alpha cells pala yung green. Isang layer ng alpha cells sa itaas, alpha cells sa ibaba, nandun yung mga blood vessels, tapos isang makapal na layer ng pula. Yung pula ang beta cell. Nasa gitna yung beta cell. Kamukha rin pala sa rat, nasa gitna yung beta cell. Nasa magkabila ang dulo yung alpha cells. Pero through the development of the pancreatic islets, no, yung layer na yan, yung sheet na yan, no, nakakrampol, nabibilog siya unti-unti hanggang sa maging isang ball siya. Nung tiningnan ni Langerhans, isang portion lang nakita, kaya tinawag niyang, sinabing it's an island pero it's more of a ball. Kaya makikita nyo, no, ang nangyari pagka na-crumple na siya. Isa na siyang ball. At yan ang nakita nila doon sa mga slices. Sa slices of the islets of Langerhans na in-stain nila. So that was a very, very big explanation of the anatomy, or histoanatomy. At saka next time pag-usapan natin yung physiology niya, no? Pero konti lang sa physiology ngayon. Kasi dapat magkadikit yung 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 histology at saka yung physiology, no? Yung alpha cell, yung beta cell, may beta cell, they talk to each other. That's why they have to be mingled together. Magkakatabi sila dapat, no? Yung beta cell na ginagawang insulin, maraming effects yan sa negative ang effect niya sa alpha cell. Ini-inhibit niya ang glucagon. Yan ang effect ngayon ng insulin. Ang delta cell gumagawa ng somatostatin, may effect din siya sa alpha cell. Ang ibang mga cells meron din ginagawang mga secretions Pag ang secretion, ang effect niya on the same cell, no? Halimbawa sa alpha cell gumawa siya ng secretion, at ang effect sa alpha cell din, ang tawag doon autocrine effect, autocrine, pareho. Pero pag ang effect naman from one cell to another, ang tawag naman doon paracrine effect. Paracrine effect naman. Pero pag ang effect sa cell na hindi katabi kundi nasa malayong lugar ay endocrine. Endocrine effect naman yun. Yan, in a nutshell, that is the reason why the cells are juxtaposed, no? Magkatabi sila, no? At hindi pwedeng maihiwalay yung alpha cell dun sa beta cell. Now, bakit ba nagkaroon ng diabetes, no? This is what Dr. Danny will talk on later on also, and what Dr. Ang explained to you, no? Pero just to emphasize, no? Sa normal individual, yung beta cell gagawa ng insulin. Pagdating sa alpha cell, i-inhibit niya yung glucagon. Kaya mababawasan ang glucagon production. Alam niyo naman, mangyayari pag nabawasan ang glucagon production, less ang production ng sugar. Mababa blood sugar, less glucagon. Pagka may diabetes at may insulin resistance, yung insulin hindi tumatalab dun sa alpha cell. May insulin resistance sa level ng alpha cell. Kaya ngayon, hindi na didiminish ang glucagon production pagka may diabetes. Gawa ng glucagon at gawa ng sugar yung glucagon. Saan ba effect ng glucagon? Di ba sa liver? Saan ba ang first pass ng lahat ng secretion ng islets? Di ba? Liver din. Kaya sa diabetes, may overproduction ng sugar from the liver kasi may hyperglucagonemia as well explained by Dr. Ang. Hihintayin ko yung kanyang lecture when it comes to treatment. Yan ang aabangan natin. Meron kayong mga tanong bago natin tapusin ang ating kwentuhan? Baka meron kayong gustong i-share din. Meron tayong a few minutes bago kunin uli ng ating MC na si Dr. Marcy Cruz ang aking microphone. Pag kinuha ni Dr. Marcy Cruz microphone ko, hindi na ako makakasalita. Meron kayong mga tanong o gusto nyong i-share sa portion na to? Dr. Marcy, wala nang tanong?
Tinitingnan ko nga kuya kung may tanong sa chat box eh.
Ayun, baka gusto nila magkwentuhan kahit na ano. Kwentuhan portion naman to eh. Kahit na ano gusto niyo ikwento. Open tayo dyan.
Okay. So kuya, talagang parang sa nakita natin, we are made by God so perfectly na merong positive and negative na mga cells na talagang magiging perfectly responding to what the human needs. Kaya lang, nasisira natin.
Yes.
Yeah.
Parang ang religious natin ngayon.
Kasi nakikita ko yung how wonderful the physiology as well as the anatomy on how we are made na sa cells na yan, sa napakaliit ng particles na yan. Nandoon pa rin yung perfection ng kanyang creation. Kaya naa-appreciate ko kung paano tayo ginawa. So, hindi lang tayo winalk through ni Kuya. Talagang pinaliwanag niyang mas maliwanag pa, simpler than we heard it, parang mas lumuwanag pa kesa doon sa dinagdagan pala ang sinabi ni Dr. Ang na mas lumiwanag and simpler to understand. So, is there any questions? Pwede niyong i-chat box, pwede kayong mag-raise ng hands. Kung wala ba tayong question for tonight? O kuya, balita ko na bakunahan ka na. Kamusta? Meron bang side effects ang Sinovac mo?
Okay ako.
Walang side effect?
Wala.
So, gusto ko nga i-share na sa balita ko sa mga taga Maynila, no? Napakadaming side effect ng isang vaccine. Ano ba kuya ang nakuha mong vaccine?
Sinovac.
Oh yeah.
Pumirma ako kaagad eh. Sabi ko kung anong unang dumating, magpapabakuna ako. Nauna yung Sinovac. Ayun, tapos na ako kaagad. Kasi tinawag ako agad. Nasa listahan ako ng priority list ng Department of Health. Nasa master list ako ng Department of Health eh. Tinawag kami tinawag ako last Thursday. Last Friday. Wala ko na-feel na side effect. Siyempre, yung the usual na may injection. Pero tama ka kamo eh. Doon sa iba nagkaroon ng nagkaroon daw ng mas maraming...
What I heard from yung other vaccine with AstraZeneca, ang daming mga na-confine because they had fever, chills, body malaise for 48 hours. Kaya parang mas maraming nadidinig kami doon kaysa sa Sinovac.
Hintayin natin yung sasabihin ng mga experts bago tayo gumawa ng conclusion niya. Kasi kung tayo lang, nagtatalo kami. Sabi sa akin, dahil daw sa wala akong naramdaman baka tubig lang daw in-inject sa akin. Samantalang isa, very potent napaka-potent na nagkaroon sila talaga ng immune response.
Placebo daw yung Sinovac. ni Dr. Eloy.
Yan,
Kasama
meron
rin
na
ni
kasi.
Dr. Eloy.
Ate Mars, tanongin mo si Dr. Rima. Astra yan eh.
Oo, medyo masakit. Masakit pa rin hanggang ngayon konti. Pero wala akong myalgia.
Oo, but yung iba nagkakaroon ng sobrang myalgia.
Wala, hindi naman ako nag-fever. May konting soreness lang sa arm. Other than that, wala na. Okay lang.
Yung daw nagka-COVID na at nagpa-Astra, sila daw ang usually nagkakaroon ng
Yes.
vaccine
Yun
side
ang
effect.
narinig ko. Yeah.
Yes. Ngayon, ayaw nang magpa-second vaccine. Pwede ba yun? Ang gusto nila second, Sinovac. Hindi pwede. Hindi ko alam kung ano mangyayari.
Oo, sabi
Pero-
ni Dr. Lasatina, Tomas Lasatin, side effects is overrated.
Oo.
Palagay ko rin.
Oo nga.
Meron po ganung mga trial na ginagawa sa UK. Magkaibang vaccine yung first at saka second dose.
Oh, maganda yun.
Oo.
Hintayin natin yung results nan.
Meron silang
Interesting yan. Oo. Oh, Dan, ano hula mo sa makikita nila doon sa study na yun?
Pareho lang, sir.
Efficacious o non-efficacious?
Sa tingin ko,
Hula.
efficacious yan.
Oh, efficacious? Oh, hula lang naman eh. We can be wrong. We can be right. We can make hula. Total naman. We can be wrong and we cannot be judged. Kasi we do not know the answer. Eh.
Maganda nga yung
Pero-
madaming klase. Para iba-iba protection.
Hula ko, efficacious din eh. Hula ko.
Okay. Wala na po bang tanong? Anybody who want to share ng experience nila with the vaccine kung na-vaccinate na kayo?
Si Rene. Rene, anong na-receive mo, Rene? Kasi Dr.
Nasa si Rene?
John. Nabakuna na si Rene. Rene. Magsalita ka, Rene.
Nag-CR si Rene.
Kaya si
Actually,
Faye, nakita ko na yun.
Ang comment si Faye, sa edad daw ni Dr. Grace de los Santos, wala naman daw siyang naramdaman.
Nagutom lang si Mami po.
Nagutom lang daw.
Oo. Tama,
Okay
siya
yun.
nakakagutom. Kasi
Eh,
Ako antok eh.
Ano wala rin eh, di ba?
Fatma, nandyan, na vaccine na yun. Nakita ko pinost sa Facebook eh.
Ako antok.
Maganda ngayon sa ibang vaccination center may merienda.
Wala sa amin, Dok. Eh. Tubig lang.
May pagkain.
Kami nga, tubig.
Habang ino-obserbahan na
Tubig lang po.
Pagkain.
Naghahanap yung ibang doktor ng pagkain.
Sobra. May vaccine na, may tubig pa, may pagkain pa.
Nagutom.
comfort.
Pero yung iba na overexcited or tense, nagkakaroon ng hypertension. Meron kaming mga news dito sa amin. Dahil na-excite sila or may tension sa pag-receive ng vaccine. Nagkakaroon sila ng parang hypertension on that day. Tapos wala naman din pagkaraan. Hindi naman sila hypertensive. Okay? So, with that, wala na po bang tanong? Natatakot.
Ang haba daw ni Del.
Mahaba needle. Okay.
Dala kayo ng needle nyo.
Hindi,
Gauge
sir, naka,
26
na yun,
para hindi masakit. Gauge 26.
Naka-prepare na.
Gauge 26 yung ginamit sa akin kasi naka-maintain daw ako ng aspirin. Dahil doon, siyempre may blood thinner. Kaya pag may blood thinner, they use a smaller gauge syringe. Pwede man dala kayo sa syringe. Or needle para maliit.
Okay. So, let's proceed. So, we'll just play a video of PSD sa mga na-vaccinate na.
Nakamute. Ate Marcy, nakamute.
Good evening again, friends and colleagues. Let's start our program proper. Uh, Please, tonight we have two wonderful lecture. Pero I want to remind everyone that you have to write your name in the chat box that serves as your attendance. And right after the lectures, this will be followed by the Q&A. So let's proceed with a short video of our partner, Warwag. Then this will be followed by a short message by Mr. Mike Cruz, the marketing manager of Warwag.
So good evening po, mga doctors. I'm Mike Cruz po of Borag Pharma Marketing Manager. So thank you very much po for gracing this event tonight. We truly look forward po for such activity. We're able to partner with you and share updates po from coming from our experts. We at Warwag po is embarking really to reach out po a lot of doctors basically where our products could be beneficial to your patients po. We hope po that the lecture tonight with our speaker will help you in the management po of your patient who has diabetic polyneuropathy. And we look forward po to more partnership in the future. So together po with the PSD, together with Warwag Pharma, let us empower po health-conscious patients with highly effective solution to prevent po and treat lifestyle diseases po. So thank you again and have good evening po.
Thank you. Thank you, Mr. Mike Cruz. So our first topic for tonight entitled Diabetic Polyneuropathy, Pathogenic Treatment with Thiotic Acid. This will be lectured by Dr. Jamie Agra, a faculty of UERM, ISDFI, Vice President on Consortium of Government Diabetic Clinics. Presently, the Secretary of ISDFI Alumni Association. He had his residency training in internal medicine in Veterans Memorial Medical Center and had her fellowship training in clinical diabetology at UER MMC. So with that, let's introduce Dr. Jamie Agra.
Wala. Hello? Nag-share na?
Nag-share
Margie?
Yes po,
na,
Doc. Yes
kaya lang
po.
yung pinaka-computer ko pa.
Hindi ko makita. Teka, bakit ganito? Ba't ganon? Hindi ko siya nakikita. Sir Larry, ba't di ko siya
Oo,
nakikita?
Opo,
Hindi ko
Dr. Day,
nakikita yung slide ko.
click niyo po yung PowerPoint doon sa taskbar sa baba. Tuwain niyo po. Yan po.
Ayan, okay na?
Slideshow view.
Kita na?
Opo,
Slideshow view eh. Yung lahat ng slides
Ayan, andyan na.
Yan, okay.
So, thank you, Dr. Marty, for that kind introduction. My topic today is about DPN, pathogenetic treatment with thiotic acid. Ayaw. Ayaw mag-lumipat. Yun. After this presentation, you shall be aware about the importance of diabetic neuropathy. In this presentation, you will learn about the pathophysiological processes behind the condition. A knowledge about available neurological tests will be refreshed, and an overview of the available treatment option will also be included in this presentation. Diabetes is a serious threat to global health that respects neither socioeconomic status nor national boundaries. As to the latest data published in the IDF Diabetes Atlas 9th edition last 2019, showed that 463 million adults are currently living with diabetes. And without sufficient action to address pandemic, 578 million people will have diabetes by 2030. And this number is expected to jump up by 51% up to a staggering of 700 million by the year 2045. Patients with type 2 diabetes face a chronic progressive disease that lead to complications that profoundly affect both quality of life and longevity. Diabetic vascular complication is a leading cause of end-stage renal failure, acquired blindness, a variety of neuropathies, and accelerated atherosclerosis, which could account for disability and high mortality rate in patients with diabetes. Diabetic neuropathy is the most common and troublesome complication of diabetes, leading to greatest morbidity and mortality, resulting in a huge economic burden for diabetes care. As noted here in 2017 issued of Diabetes Care Journal, about 58% of adult diabetic patients in the Philippines were diagnosed with diabetic neuropathy based on nerve conduction study. Type 2 diabetes develop and progressively worsen over time as seen in this slide. Initially, increase in insulin resistance and impairment in beta cell function interact. Over time, resulting in relative insulin deficiency as well as excessive glucagon production, leading to an overproduction of endogenous glucose in the liver. In response, the first postprandial and then fasting blood glucose level begins to rise. Therefore, in hyperglycemia worsens or the underlying pathophysiologic defect in type 2 diabetes. It is also an independent risk factor for macrovascular complication in diabetes, and the risk of which begin to increase even during pre-diabetes phase. Therefore, in hyperglycemia, it also directly leads to the microvascular complication in diabetes. In this table, you can see that the risk of neuropathies like DSPN and CAN is already increased even at the start of prediabetes, especially in persons with combined IFG and IGT. Therefore, diabetic neuropathy should not be considered as a late complication, but rather an early complication. Mitochondria, which is the powerhouse of the cell, is another important source of reactive oxygen species. With normal glycemia, enough ROS can be produced and help in using glucose as a source of cell energy. However, with hyperglycemia, it creates systemic overloading in the mitochondria, leading to an imbalance of free radicals and antioxidant in the body identified as a causative factor of neuropathy, which is the oxidative stress. This oxidative stress leads to cell and tissue damages, where in diabetes, it contributes to the development of microvascular complication. Here a schematic summary showing the element of unified mechanism of hyperglycemia-induced cellular damage. In intracellular hyperglycemia developed in the target cell of diabetic complication, it causes mitochondrial production of RAS. With a decrease of GDPDH or glyceraldehyde 3-pyrophosphate dehydrogenase activity activate polyol pathway, hexosamine pathway, plaques, PKC pathway, and increase in AGE pathway. Each pathway has different defects, leading to the damage to diabetic micro and macrovascular complication. There are several forms or patterns how diabetic neuropathy are being presented. Among those diabetic neuropathy, DSPN or the distal symmetric sensory motor polyneuropathy is the most frequent clinical manifestation that make up 75% of all diabetic neuropathies. It approximately 50% cases coincident with autonomic neuropathy that control sensory and motor function. It usually spread from distal to proximal, presenting a stacking globe pattern. As that disease progresses, nerve damage spread in a direction of the legs and hand and usually distributed in a symmetrical pattern. DSPN has paradox. Persistent neuropathic pain characterized as paresthesia, burning, numbness, and pain that interferes significantly with the quality of life, impairing patient sleep and recreation. It also significantly impacts emotional well-being and associated with if not caused by depression, anxiety, and loss of sleep. However, with asymptomatic, non-painful, but with less symptoms like presence of decreased temperature and decrease in pain sensation can be more risky, leading to a diabetic foot syndrome. And these are prevalent among diabetes, an equivalent of 30%. Here, a simplified view of a peripheral nervous system description of the underlying cause of a small and large fiber neuropathies. The alpha large myelinated fiber is in charge excuse me, of the motor function and muscle control, while the alpha and beta myelinated fiber with sensory function for the touch, vibration, position, and perception, while the delta, a thinly myelinated fiber, is in charge for the cold, perception, and pain. While with the C fiber, can be myelinated and unmyelinated and have both sensory and autonomic function dysfunction. That comprising to the heart rate, blood pressure, sweating, GIT, and GUT function. In this study of the PROTECT study, wherein a nationwide educational initiative done in Germany among 1,850 participants. Among those participants, 781 had no history of diabetes, while 121 had type 1 diabetes and 942 with type 2 diabetes. And around half of the participants in the educational initiative has DSPN was previously undiagnosed, for about 70%. Since many cases of neuropathy and diabetes remain undiagnosed, therefore, effective strategy to timely detect both conditions should be implemented. For examination for DSPN, if you were testing for the large fiber, tuning fork testing for the vibration sensation can be used. If you want to test for the pressure sensation, a 10-gram monofilament test can be done. While for the reflexes, the neurological hammer is used to test for this target nerve fiber function. How about for the small fiber function? If you're testing for the pain sensation, pinprick or neurotip test can be done. And for the temperature sensation, it is the tip term test can be used. There are several, these are the recommendations from the ADA for screening of DSPN. For type 2 diabetes, testing should be done at the time of the diagnosis of type 2 DM. But for type 1, it can be done 5 years after being diagnosed. Upon diagnosis, either type 1 or type 2, this should be done at least annually thereafter. For pre-diabetes screening who have symptoms should also be considered. Remember that up to 50% of cases of DSPN may be asymptomatic. This one showed that therapy success depends on the amount of reversible abnormalities. As you can see here, the earlier the therapy started, the better outcome for the DSPN to be treated or to be relieved. There are three cornerstone for the DSPN treatment. The first pillar is optimization of blood glucose control and management of additional risk factor. Here, has been estimated between 3 to 25% of persons with diabetes may experience neuropathic pain. But for patients diagnosed early with type 1 diabetes, tight blood glucose control can reduce the risk. Compared to the type 2 diabetes, even with the long-standing it only reduces the risk by 5 to 9%. Therefore, even tight glycemic control at best limit the progression of neuropathy in patients with type 1 diabetes can be achieved, but does not affect DM neuropathy in patients with type 2 DM. The third pillar is about symptomatic treatment of neuropathic pain. In this slide, you can see that among the treatment for neuropathy, the only medication that are pathogenesis drive therapy can be seen with the alpha-lipoic and the benzodiazepine. Then we'll proceed with the second pillar about the blockage of the pathogenetic glucose metabolizing pathway. All patients clinically diagnosed for DSPN with presence or absence of neuropathic symptoms should undergo lifestyle modification, control of CVD, and other risk factors. For the assessments of comorbidity and potential for drug interaction, it can be classified as asymptomatic DSPN, symptomatic not painful DSPN, and painful DSPN. When treating for asymptomatic DSPN and symptomatic not painful, and also with the painful, using pathogenesis-derived treatment can achieve lessons of the DSPN or the pain. Example of the pathogenesis-derived treatment are the alpha-lipoic, the benzodiazepine, and the actobergin. Actobergin is a medication that comes from the physiologic amino acid mixture made of the extract of calf blood and ultra-filtered calf serum sourced from the calf. So hindi siya yung conventional usual na treatment for neuropathy. But for the painful neuropathy, analgesic treatment use are as followed. It can be treated using pharmacotherapy and the non-pharmacologic treatment. Among the non-pharmacologic treatment to be used are the TERN, which is the transcutaneous electrical nerve stimulation, or the PREM, the frequency modulated electromagnetic neutral stimulation, and the high tone, acupuncture, and etc. If these treatments are refractory, then you can combination with the pharmacotherapy is needed to achieve the treatment for the DSPN. Here are the choices among those pharmacotherapy. So with regard to the DSPN, it is our take-home message that most common clinical manifestation accounting about 75% of diabetic neuropathy. That an increased prevalence of neuropathy can already be detected even in pre-diabetic state. So therefore, it is not be classified as an early classified as an early complication rather than a late complication. Kasi kung mapapansin nyo, yung unang mga slide na present na merong DSPN asymptomatic, symptomatic but not painful. So meron na silang neuropathy pero hindi pa ganun siyang, hindi pa presented yung sobrang yung sakit na nararamdaman ng frank DSPN. Up to 50% of the cases may be asymptomatic. Therefore, regular screening is important. And treatment for DSPN should be multimodal considering the individual risk profile, pathogenetic treatment, pain management using pharmacotherapy, as well as the non-pharmacological option or in combination if required. One example of treatment used for DSPN, the pathogenetic therapy is the alpha-lipoic acid, or known as the ALA. ALA is also has a synonym biochemically known as thiotic acid. It has a unique amphiphilic character, having both hydrophobic and hydrophilic properties. Alpha-lipoic suppresses oxidative stress by direct and indirect mechanism. ALA is a radical scavenger that scavenges harmful oxygen both in aqueous and in fat-soluble cell environment that counteract sensory disorder in diabetic polyneuropathy. Here, show that oxidative stress is enhanced in patients with diabetes before the development of DSPN, but to an even higher degree in those with manifest DSPN. Here, one study on the effect of the antioxidant alpha-lipoic acid, thiotic acid, were studied in 3 weeks multi-centered randomized double-blind placebo-controlled trial. This was done in 328 type 2 diabetic patients with symptomatic peripheral neuropathy. They were randomly assigned to treatment with intravenous infusion of alpha-lipoic acid using 3 doses such as 100, 600, and 1,200 milligrams per day. The neuropathic symptoms characterized as pain, burning, paresthesia, and numbness were scored at baseline and at each visit prior to infusion. In addition to this, Hamburg Pain Adjective List, a multidimensional specific pain questionnaire, was given to the patient, and the neuropathic symptom and disability score were assessed again from the baseline to day 19. According to the protocol, 260 patients completed the study, and the response rate after 19 days defined as an improvement in the total symptom score of equal or more than 30%. And the total scale of the pain adjective list is significantly reduced, as well as the rate of adverse after 19 days. Therefore, these studies substantiate that intravenous treatment with alpha-lipoic using a dose of 600 milligrams per day is superior to placebo in reducing diabetic peripheral neuropathy without causing any significant adverse reaction. Another study, the Sydney 2 study, this is a randomized double-blind placebo-controlled trial for 181 diabetics from Russia and Israel. They are divided in 4 treatment groups receiving ALA, but this time in oral preparation at a dose of 600, 1,200, and 1,800 milligrams compared with the placebo for 5 weeks. After 1 week, the run-in period, the aim of this study was with the first outcome to measure changes from the baseline of TES, or the total symptom score noted as stabbing, lancing pain, burning pain, paresthesia, and asleep numbness. And the second endpoint is the TSS, NSS, or neuropathic score and neuropathic impairment score, and patient global assessment of efficacy. For the conclusion on this study, oral treatments with ALA for 5 weeks improved neuropathic pain and deficit in patients with DSPN. By using ALA, even at a small dose of 600 milligrams, provide an optimum benefit ratio. Another study is the Nathan study. The result for this study examined a long-term effect of ALA on electrophysiology and clinical assessment. This study was presented in ADA meeting last 2007. It changed from the baseline was significantly better with ALA than placebo with NIS lower limb, and the muscular weakness score. More patients showed clinically meaningful improvement and fewer progression of the neuropathy impairment score, as well as the neuropathy impairment score of the lower leg. The post-hoc analysis of this Nathan's 1 study state that ALA is particularly effective in patients with longer duration of neuropathy and diabetes, and in patients who already develop more severe stages of diabetes, neuropathy, and CVD. Here are several studies done to test for the benefit and safety of ALA. It's about 14 studies where all authors had a conclusion that oral ALA or alpha-lipoic acid at a dose of 600 milligrams once daily has an effect on diabetic peripheral neuropathy symptoms identical to those IV preparation of ALA treatment. And the pain reduction associated with different treatment has shown that ALA has a high chance of 50% pain reduction. In this study done by Rosman, conducted a verifying interesting study on the real-world effect of switching alpha-lipoic to conventional symptomatic treatment in diabetic neuropathy. About 443 treated patients with ALA for an average of 5 years was then asked to stop their medication and divided these patients into 295 patients were started on gabapentin and the rest 150 remain untreated as they do not have any significant symptom. Out of the 150 who were untreated, 110 developed neuropathy symptoms within 2 weeks of cessation of ALA. While in the gabapentin group, 132 or 31 individuals responded to the treatment, while 161 of the 293 did not respond to the treatment. The responders were treated with pregabalin, carbamazepine, amitriptyline, tramadol, or morphine as monotherapy or in combination. But among the responders of the 131, patients who are forced to stop gabapentin treatment due to their side effect. And the visit to the doctor from initially of 131, 3.8 in 3 months, what with ALA has been increased to 7.9 times in 3 months for those patients treated with gabapentin or medication alike. Also, the monthly cost of ALA was less than the conventional medicine. Therefore, in this study, researchers concluded that switching the ALA to pain relief medication can be an expensive decision both regarding the cost and patient health. Another thing in this study done by the Journal International Medical Research in 2018 showed that the treatment with 600 milligram ALA per day for 40 days improved symptoms of neuropathy and neuropathic pain in patients with diabetic neuropathy. ALA improved overall daily functioning of patients, reduced work and social life disability, with a 50% of the patients reported feeling very much better or much better after the treatment. So, for the consideration in clinical practice, ALA should be taken on an empty stomach, while in order to achieve a maximum absorption, and it should be taken 30 minutes before breakfast. And ALA, being a metal chelator, should not be administered at the same time as other metal compounds. ALA has been seen to have insulin mimetic effect by directly and indirectly interpreting the insulin signaling cascade. Therefore, monitoring of blood sugar level, particularly at the beginning of the treatment. In individual cases, doses of insulin and oral anti-diabetic agent must be adjusted. So for a take-home message regarding ALA or the thiotic acid, oxidative stress play a major role in the pathogenesis of DSPN. ALA is a universal and potent antioxidant. Has been proven by several randomized clinical trials and meta-analysis compared that the beneficial effect of ALA on neuropathic symptoms in patients with DSPN. And long-term data point toward the effect of ALA on neuropathic deficit has and slowed the disease progression. Therefore, ALA is suitable for long-term pathogenetic treatment of DSPN and can be safely combined with symptomatic analgesic like pregabalin. With our sponsor Worldwide, they had this preparation of ALA known as the thiogamma presented in 600 milligrams per oral film coated tablet. Again, it should be taken 30 minutes before the first meal and should be taken whole with plenty of fluid. If you're going to ask me why 600 at walang preparation of 1,800, 1,600 as done in the trial, kasi nakita nila na mas maraming nangyayaring GI side effect using that higher dose. That's why and all the study had shown that with a dose of 600 milligrams, so much improvement na nakikita with the DSPN. And with that, thank you for your kind attention.
Thank you, Jamie, for introducing a new choice of drugs for DSPN. So we'll proceed with our second lecture with we have the continuation of the Alpha Cell series with the topic Metabolic Effect of Glucagon Beyond Glucose Homeostasis. Our speaker, Dr. Radani Baltimore, a diplomate and fellow of the Philippine College of Physicians, immediate past president of the Central Luzon PCP chapter, the vice president of Philippine Society of Diabetologists, and a faculty of ISDFI, and a consultant in Heart of Jesus Hospital, San Jose City, Nueva Ecija, and also in the PJG MRM Medical Center, Cabanatuan, Nueva Ecija. With that, take it away, Danny.
Thank you. Can you hear me?
Yes, Danny.
Thank you. Can you see my slide?
Yes.
Wow. So, good
Nakalagay
evening.
pa.
Welcome to Astoria Plaza. The series about glucagon is supposedly yan yung ating workshop last year. Okay, but again because of this problem, hindi naman nag-push through, kaya March pa rin naman tayo nagkaroon ng PSD Select 2. Okay? So thank you very much again sa ating sponsor for this meeting, yung ating pharmaceutical company na trend yung Worldwide. Okay? So last time, napag-usapan sabi na ni Dr. Ernie ang tungkol about introduction about glucagon, and now it's my task to talk about the metabolic effects of glucagon beyond glucose homeostasis. So medyo it took mga isang taon mahigit para aralin to kasi medyo mahirap, or you need to review everything about the biochemistry, the physiology, tapos yung embryology. So inaral namin lahat yan. At hopefully may mapulot tayo ngayong gabi dito sa lecture on glucagon. So this topic is divided into three parts. We'll be talking about the critical regulation of energy metabolism, on the beneficial effect on body fat mass, food intake, and energy expenditure. Second, we'll talk about the liver alpha cell axis in type 2 diabetes, the glucagon and the heart and kidneys in type 2 diabetes. Okay? But yung mga succeeding lectures natin, we'll talk about more on the pathology on glucagon in type 1 diabetes and type 2 diabetes. So yung sa akin po parang overview lang po ito ha, kaya sa tingin ko medyo mas madali para sa atin. We know the ominous octet by Dr. Defronso. So sabi niya, there are 8 problems in diabetes that causes hyperglycemia. So you have the different organs involved, like your liver, your beta cells, your muscles, your fats, your kidneys, your brain, and your intestine. But we'll focus more on the alpha cells because of there is an increased glucagon secretion. Okay? But I'll be talking more on the normal, okay, in physiology. Now, the role of your this is the role of your glucagon, of the role of the pancreas in uh, blood sugar regulation. So you have the different cells types, particularly your beta cells, which is about 60% of the pancreas, okay, of the islet cells. You have the delta cells, and then you have 40% comprising of your alpha cells. So this is responsible for the glucagon. So in a normal glucose level, when the patient has increase in blood sugar or hyperglycemia, the pancreas will be stimulated to uh, release your insulin. Okay, so this would stimulate glycogenesis in the liver. So itong topic natin ngayon to is more on the biochemistry ha, kaya brace yourself. So marami pa tayong pag-uusapan tungkol dito. So when insulin is released, it would convert your glucose to glycogen in the liver. Okay, so there will be glucose uptake by the cells. So the plasma glucose returns to normal levels. When the patient is experiencing a decrease in glucose or hypoglycemia, your pancreas will be stimulated to release your glucagon from the alpha cells. So your glucagon would stimulate gluconeogenesis and glycogenolysis in the liver and thus release glucose in the plasma, making it possible that the plasma glucose returns into normal levels. Diba? Ang dali lang naman. Now, again, so from the islet cells of the Langerhans in the pancreas, your insulin, the secreting beta cells, and you have the alpha cells secreting your glucagon. So when glucagon is secreted, dito sa liver, ito yan, meron tayong mga receptors. So you have the glucagon receptors, and then when glucagon stimulates the glucagon receptors or attached to the glucagon receptors, it would undergo the process of glycogenolysis and gluconeogenesis. So, yan ay magpo-produce ng glucose in the bloodstream. So, this would in turn cause hyperglycemia, oxidative stress kung sumobra naman na, and then eventually would lead to diabetes complications. Now, paano ko ba ito maalis? Okay, so question. How many amino acids are there in the insulin? Kung naaalala nyo pa. Anong sagot? Tama. Meron tayong alpha, chain at saka beta chain. Sa alpha chain, meron tayong 21 amino acids at sa beta chain, meron tayong 30 amino acids. So, sigurado walang nagkamali sa inyo ito. Now, paano naman yung glucagon? How many amino acids are there in your glucagon? Mas mahaba ba ang glucagon kaysa sa insulin? O mas maigsi siya? Okay. So tama rin kayo uli. Sa glucagon, merong 29 amino acid. So mas maigsi siya. Okay? But the proglucagon is very long. So your glucagon is a 29 amino acid peptide synthesized and released from the pancreatic alpha cells. So it is produced by the cleavage of your proglucagon by the prohormone convertase 2. It exerts its biological action through the activation of your glucagon receptors. So minsan mababasa nyo o makikita nyo ang abbreviation niyan ay GCGR, okay? Which stands for glucagon G protein coupled receptor. So minsan glucagon receptor o kaya G protein coupled receptors. And these are found in the various parts of the body, including the liver, the kidney, the adipose tissue, the brain, and the pancreatic beta cells. Okay? So, meron ba tayong na-miss sa ominous octet? Makita natin, no, di ba? Halos lahat nandito. Now, ano ang nawawala? Mamaya sasabihin ko. So, it is regulated by different mechanisms. So, there is a direct signaling of the alpha cells, merong indirect signaling of the alpha cells by the beta cells and the alpha cell secretory products. Okay? Meron din autonomic nervous system ang nagre-regulate sa secretion ng ating glucagon, the gut incretins, and an array of autocrine signals, particularly coming from your insulin at saka yung somatostatin. Okay? So, ang dami nagre-regulate sa glucagon. Now, with postprandial hyperglycemia, it would stimulate insulin secretion, diba? And then act on the liver to suppress the glucose production. Concomitantly, pag tumaas ang blood sugar levels, it would suppress glucagon secretion kasi yung insulin ang kailangan mo. Thus, it would reduce its stimulatory effect on the hepatic glucose production. Sino pong gusto mag-explain? Ako na lang. So makikita natin dito sa diagram, di ba? This is the alpha cell. So it has a similar, di ba? Pag dinidiscuss natin yung beta cells. So dito sa alpha cell naman, makikita natin na kapag mababa ang blood sugar or there is hypoglycemia, mababa ang glucose sa loob ng cells. Kung mababa ang glucose sa loob ng cells, kakaunti lamang po ang ating ATP. And this decrease in the ATP inside the cell would close the ATP-sensitive potassium channels. Okay? So, hindi makakapasok sa loob ng cell ang potassium. So, kakaunti yung potassium. Thus, kung mag-close ang ATP channels, this would cause a depolarization of the plasma membrane, leading to opening of the voltage-dependent calcium channel. Okay? So pag nagbukas na yung calcium channel, papasok yung mga calcium inside the cells, causing the release of your glucagon outside. Okay? Siguro natatandaan nyo din yung sa beta cells, di ba? Bubukas, sasara, bubukas, sasara. Ganun din sa alpha cells. Okay? And this is stimulated by your hypoglycemia. Now, pag lumabas na yung glucagon, saan naman na siya pupunta? So, mas-stimulate niya naman itong mga cells sa liver. Okay? So, example, ito yung glucagon. Diba? Ito yung glucagon receptor. So, glucagon receptor is a seven-membrane protein in the plasma membrane. Okay? So, yung glucagon would attach to it. So, ito yung GC, yung G protein. Okay? And then it would stimulate the receptor. Okay, so yung glucagon S alpha would stimulate the adenyl cyclase, yung AC. So, magkukos yan ng mga reaction, yung ATP magko-convert into cyclic AMP. Okay? Itong cyclic AMP na to would in turn produce more of your PKA or your uh, anong tawag dito? Uh, protein kinase A. Okay? So, pag yung protein kinase A dumami, it would activate the enzyme phosphorylase kinase. At pag na-activate naman tong enzyme na to, itong glycogen phosphorylase, which is inactive, it would be activated to glycogen phosphorylase active. At itong enzyme na to would in turn stimulate your glycogenolysis. Itong PKA naman would stimulate or your other enzymes, particularly your pepsi-K. At itong mga enzymes na to, yung G6 phosphatase, would in turn increase your gluconeogenesis, decrease your glycogenesis, and increase your glycolysis. At itong mga process na to would in turn increase your glucose. Okay? Kaya mawawala yung o mababawasan yung hypoglycemia. So, again, remember, ito lang po yung maganda tinatandaan natin because we are specialists or diabetologists. So, glucagon would attach to the receptor or glucagon receptors, particularly stimulating your adenyl cyclase, increasing your cyclic AMP, particularly increasing your or activation of your protein kinase A. Yan yung pinaka-importante because this process is also what we will see in other parts of the cell or other cells. Now, sabi natin, sa hepatocytes nakikita yan. Okay? So, in the hepatocytes, there are receptors for glucagon and epinephrine. Ganyan din yung nakikita natin, yung counter-regulatory hormones will control the same process, but mas o more ang control because of your glucagon. Now, kanina pinakita ko yung mga iba-ibang cells. So makikita natin dito that the muscle cells has only receptors for epinephrine. Wala po siyang receptor sa glucagon. Okay, remember this. Sa muscles, walang receptor sa glucagon for glucagon. Now, this is the mechanism of action of your glucagon. Again, your glucagon would bind to the G protein receptor on the hepatic cells, thus stimulating the alpha subunit exchange or your GDP for your GTP. So, ma-stimulate niya yung adenyl cyclase to increase your cyclic AMP. Okay? So, pag dumami na uli yung cyclic AMP, it would activate your PKA or your protein kinase. So, pag na-activate yan, okay, it would lead to the catabolic process and also the activation of these enzymes would inhibit, okay, ito naman yung anabolic process. So, ang galing-galing, di ba? Halos sabay sila nagkakaroon ng chemical reaction. Okay, so activation of your glycogen and your lipid breakdown and gluconeogenesis, and then at the same time, it inhibits glycogen formation and protein in lipid synthesis. Okay? Now, so ulitin lang natin. So again, when your glucagon attaches to the glucagon receptors, it would stimulate your cyclic AMP, causing activation of your PKA. Meron pa tayong isang player, yung CRED. Okay? So, the CRED is responsible for, in the nucleus, would be responsible for increasing your G6 phosphatase and increasing your pepsi-K, thus leading to gluconeogenesis. Pag na-activate naman yung PKA, meron namang another enzymes, yung FDPase or your fructose 2,6 biphosphatase protein and your phosphofructokinase 2. So ito naman would lead to decrease in fructose 6 biphosphonate. Okay? Increasing your fructose 6 phosphate leading to gluconeogenesis. Yung pKa din, ma-inhibit niya yung pyruvate kinase, kaya nagkakaroon ng decrease in pyruvate, kaya decrease ang glycolysis. It would also inhibit your glycogen synthesis, kaya pag tinignan natin, this would lead to activation of your phosphorylase kinase, kaya dumadami rin yung glycogenolysis. So, this is the aspect of glucagon signaling and its role as a regulator of your glucose homeostasis. So, nandito pa lang po tayo sa sugar ha, nire-review lang natin. Now, let's proceed now to the critical regulation of energy metabolism, which is the beneficial effect on the body fat mass, food intake, and energy expenditure. So, tapos na tayo dun sa alpha cells at saka sa hepatic cells. Okay, now, let's proceed with the activation of your glucagon in the adipocyte. Okay, so makikita natin to. So, meron ding receptors ang adipose cells. So, again, similar activation of your adenyl cyclase leading to the activation of your cyclic AMP, leading to stimulation of your pKa or your protein kinase A. So, dahil dito, okay, ma-stimulate niya itong mga proteins na to sa cell. Okay? And then, ma-stimulate niya yung coupled GI leading to activation of your adipose triglycerol lipase. Okay? Ito yan. Which will convert your triacylglycerol or your triglyceride into your diacylglycerol. Okay? So, from 3, magiging 2. At yung HSL, okay, very important to because this is the hormone-sensitive lipase. Itong diacylglycerol, magiging monoacylglycerol. At yung monoacylglycerol lipase would in turn lead to release of your free fatty acids and your glycerol. Again, your free fatty acid would be a stimulatory to your pancreas to release your glucagon. And then, ikot-ikot lang. Now, saan naman pupunta itong glycerol? Again, your glycerol would be used in the liver for beta oxidation, for glycogenolysis, and gluconeogenesis. Ito yung mga substrate to make new glucose. Okay? Also, in the liver, there would be decrease in your lipogenesis. Okay? Ano naman ang effect nitong mga ito? Now, let's dig deeper. So, alam na natin to. Siguro baka na-memorize nyo na to. Ha? So, again, pupasok yung CREB, which is your carnitine acyltransferase. This is CPT pala. Okay, yung CPT because of your CREB, PPAR alpha, and your FOXA2. There will be transcription of your CPT and CPT2 and other genes needed in the beta oxidation. Okay? So, ito yung process na papasukan yan. So, if you have the free fatty acid, papasok yan sa CPT1, yung ating fatty acyl-CoA, and your carnitine. Okay? And then this would go inside the mitochondria, leading to beta oxidation, giving rise to acetyl-CoA. So remember your acetyl-CoA yan ay papasok sa TCA or yung citric acid cycle to produce your ATPs, thus becoming your energy. Okay? Now, ito namang acetyl-CoA na to, papasok yan sa may enzyme na acetyl-CoA carboxylase. And remember sa mga previous lectures natin, very important yung malonyl-CoA. Okay? So ito isa sa mga rate-limiting enzyme or rate-limiting steps in the production of your free fatty acid. Okay? So tandaan lang natin that your glucagon would be inhibitory in this de novo fatty acid synthesis. Okay. Now, sabi natin, sugar lang ba ang effect ng glucagon? May effect din siya ha, because of the pleiotropic effect. So I will enumerate this. Sa lipid metabolism, there is decreased plasma cholesterol. The total esterified fatty acid is also decreased. Decrease ang synthesis ng hepatic synthesis of your triglycerides and apolipoprotein. So in addition, glucagon determines the lipolysis in the white adipose tissue or your WAT. Meron din siyang increased ketone body production and fatty acid oxidation. Another property of your glucagon is it increases the energy expenditure and thermogenesis by an increase in oxygen consumption, the blood flow and heat production, particularly in the brown adipose tissue. Remember yung BAT at saka WAT during the last mga sessions natin. So, your glucagon plays a very important role in the heat production in your BAT or your brown adipose tissues. So, pagka giniginaw tayo, particularly yung BAT, importante sa atin. Now, ang maganda rin sa glucagon, it decreases the food intake. With reduction in the meal size, there would be increase in satiation, possibly mediated by another hormone or ghrelin, and decreased gastric emptying. Another pleiotropic effect of your glucagon is the regulation of secretion of other hormones. So, responsible din siya, di ba, sa insulin, ghrelin, somatostatin, cortisol, and your growth hormone. Also, sa mata rin, meron din siyang pleiotropic effect. So, the loss of retinal function and of visual acuity and retinal cells death have been described after the disruption of your glucagon receptors gene. Okay? So, related dyan, particularly in mga hypoglycemia. But it was shown in the rodent models. Sa GI din, meron siyang effect. So glucagon has been used not only as an inotropic agent and vasodilator, but also as an inhibitor of your smooth muscle activity of the GI tract. Okay? So in summary, your glucagon controls your food intake and energy balance. And it is responsible also for your body weight, any energy expenditure, and thermogenesis. Okay? Now, this is glucagon and the food intake. So this is the property of the anorexigenic action of your glucagon. Sabi natin, kanina, pinakita natin sa liver, sa alpha cells, at saka sa fats. Now, let's talk about the role of your glucagon in your brain. So, the green, pag sinabing green, green yung line or yung green yung arrow, it is stimulatory. Okay? Pagka red naman, inhibitory yan. So, your glucagon, merong mga receptors dito. It would cross the blood-brain barrier. And in the hypothalamus, ito yan, hypothalamus na tayo. Okay? So, sa hypothalamus, you have the ART o yung hypothalamic arcuate nucleus. So meron din siyang receptor, so 'di ba? Meron din siyang GCR receptor o yung G-protein glucagon receptors in the hypothalamus. At kapag yung glucagon kumabit dito sa receptor na to, it would stimulate a cascade of events stimulating again your PKA, your CMK beta, leading to increase in your AMPK. Okay? So in the brain, it would lead to inhibition of your food intake. Okay? Now, again, ito naman yung neuropathy, neuroway. Okay? So, again, indirectly, in the liver, it would stimulate the cell in the liver, ma-stimulate niya rin yung vagus nerves. Dito naman ang pasok niya. Okay? Sa nucleus tractus solitarius. Okay? Again, pasok ulit sa hypothalamus. So, yan yung effect ng glucagon in the brain. So, In the body weight, energy expenditures, so nakokontrol ng glucagon din ang body weight by promoting weight loss, di ba? In physiological and pathological state seen in human and rodents. So, several data sa mga mice, nakikita nila, that would suggest that glucagon acts on the body weight. And however, this is very complex and involved food-dependent and independent mechanism. Okay? Now, just to simplify, okay? So, sabi nga natin, this is the glucagon on the energy balance regulation. So, yung brain natin, in the sympathetic nervous system, ito yung BAT or your brown adipose tissue. You have the UCP1 or your uncoupling protein 1. This would lead to the thermogenesis. Pag nagkaroon ka ng thermogenesis, this would lead to reduction in your body weight. Now, if you will see here, yung glucagon coming from the pancreas, it would increase yung FGF21, which is the fibroblast growth factor 21. Okay? At dahil dyan, pag na-stimulate yan, nagkakaroon ng increase in energy expenditure, thus leading to reduction in body weight. Meron ding effect ang glucagon with the other hormones, your growth hormones, your cortisol. Again, this would stimulate your hormone-sensitive lipase, leading to decrease in what? So, nagkakaroon ng increased lipolysis and ketogenesis, leading to decrease in the body weight. Okay. Now, sabi natin, yung BAT is the main site of adaptive thermogenesis in the body, and in which energy is dissipated as heat in response to the changes in temperature and diet. So, sa mga rats, nakikita rin din yan because there is significant elevation in the oxygen consumption. So, the more oxygen you consume, then it would lead to increase in the metabolism. So, it increases the BAT mass and to stimulate BAT thermogenic capacity in vivo and in vitro as seen in the mice. Now, after cold exposure, the levels in the circulating glucagon are significantly elevated, suggesting that glucagon participates also in the cold-induced thermogenesis. So, sabi nga natin, your glucagon administration would restore the UCP1 expression in BAT, okay, leading to increase in the circulating FGF21. Okay? So, thus, glucagon decreases body weight by activation of your energy expenditure and thermogenesis. Okay? So, in summary, this is the effect of your increasing of your glucagon. Okay? So, na-increase yung sugar, increase ang liver fat content, and increases your LDL. And there is improvement in the glucagon receptor signaling, thus increasing your lipid metabolism. So, the effect of your glucagon is stimulation of your beta oxidation, decrease or inhibit lipogenesis, and decrease your triglyceride kasi di ba na-break down yung triacylglycerol or triglycerides. Stimulates lipolysis and increases your free fatty acid to be used as substrate for gluconeogenesis. Now, again, glucagon sa lipids naman has a potent hypolipidemic effect. It decreases your cholesterol levels. Okay? It decreases your triglyceride production, your VLDL, and cholesterol in hyperlipidemic and non-hyperlipidemic rats. So, maganda yung effect ng glucagon. So again, it inhibits lipogenesis and stimulate lipolysis. By promoting lipolysis, you stimulate your hormone-sensitive lipase. So again, this is the key enzyme. Okay? So, kapag naapektuhan yung lipid metabolism, it has a direct effect on the hepatic ketogenesis. Okay? So, in patients with type 1 o yung mga nagpa-fasting, this may result into ketogenesis. Okay? So, Dr. Nines Bautista will elucidate more on type 1 on the role of your glucagon. Okay? So may lipolytic effect of your glucagon in the liver. Okay? So tapos na tayo sa first part. Let's proceed with the liver alpha cell axis and type 2 diabetes. So this is more on the role of your glucagon in the liver alpha cell axis. So kanina, puro fatty acids naman pinag-usapan natin. Ito naman, this would look in the function of your glucagon. Okay? Particularly in the liver. Okay? So makikita natin yung different functions of your glucagon in the different organs. So sabi nga natin, it affects your liver, your heart, your adipose tissues, your GI tract, your kidneys, and your brain. Again, hindi kasama ang muscle. So, makikita natin yung different actions of your glucagon. Okay? So, it decreases appetite and food intake. Napaliwanag na natin. Ito, sa glucagon, it increases heart rate, cardiac function, and cardiomyocyte survival. Sa third part of the lectures, we'll discuss more on this. Now, ito na yung importante sa atin din ngayon. Yung ureagenesis. So, again, with your glucagon, so ito yung process, yung regulation of your glucagon in the liver. So, kung marami kang glucose, okay, it would be converted into glycogen. Okay, kung konti ang glucose mo, magiging glucose siya, and then ma-stimulate mo yung glycolysis and mapoproduce ka ng acetyl-CoA. So, pag sinabing liver alpha cell axis, it pertains more on the amino acid metabolism. Okay? Ito ha, medyo nahirapan po ako dito ha. So, this is the amino acid homeostasis and the alpha cell function and proliferation. Okay? So, this is the, on your left side, is your, of the monitor, is your liver cell. Ito namang kulay green na to is your alpha cells. So makikita natin dito yung normal, di ba? At the baseline, you have the glucagon receptors. So the amino acid metabolism, pagka maganda ang receptor mo o glucagon mo, your amino acids would enter the cells. Okay? Kasi yung amino acid ang gagawin ng cell para mag-produce ka ng glucose. That is your gluconeogenesis. Okay? Now, on the other hand, kung meron kang problema sa glucose receptors o meron kang IGS, which is your interrupted glucagon signaling, magkakaroon ka ng problema. Maiipon yung amino acids outside the cell. So, meron kang hyperaminoaciduria in relation to the interrupted glucose signaling. Okay? Now, your amino acids would stimulate glucagon secretions acutely, and under sustained stimulation, it would promote alpha cell proliferation and hyperplasia. So again, sa baseline, pag tama naman ang metabolism mo. Pero pagka madami kang amino acid, there would be stimulation of your glucagon secretion, increase ang proliferation, and increase ang secretion of your glucagon. So, dadami ang glucagon. Okay? So, sobra naman siya. Okay? Ganun ang nangyayari sa liver alpha cells. So, it's a relationship of your liver and your alpha cells. So, again, going back, di ba? Stimulate mo yan. Then your CREB in the nucleus, ito yung amino acids receptor. Okay? So, papasok yung amino acid and then it would tawag dito? Mag-iiba siya. Magiging alpha keto acid siya. Your alpha ketoglutarate would be converted in your glutamate. At yung glutamate is a substrate or an amino acid that is needed inside the cell. Okay? So, papasok yung amino acid na glutamate. Okay? It would undergo process para ma-release yung ammonium. Okay? Yung ammonium, ayaw natin yan kasi it is harmful to the body. Kaya kapag yung mga amino acids masyado madami, it would release your ammonium. Now, your glutamate would be converted into your alpha-ketoglutarate. Okay? Now, ito naman ay magiging aspartate. So, this would be a substrate in your urea cycle. Pero bago tayo pumunta dyan, punta muna tayo dito. Okay? So, sa loob ng cells, there would be activation of your carbomoyl phosphate synthase o yung CPSI. Ito naman to para matapon yung ammonium inside the cell. Yung ammonium papasok dito yan with the help of your carbomoyl phosphate. Yung ornithine papasok sa loob ng cells with the help of your ornithine transcarb families, mako-convert yan into citrulline. And then your citrulline would be converted into your arginosuccinate with the help of your arginosuccinate synthase. Ito namang arginosuccinate would have two byproducts, your arginine and your fumarate, with the help of your arginosuccinase. Okay? At itong arginine na to, with the help of your, will be in return converted into urea. Itong urea would be filtered in the kidney to be disposed in the urine. Okay? Nakuha niyo po ba? So, ammonia kailangan tanggalin. So, papasok siya sa urea cycle at lalabas siya in the form of urea. So, yan yung ureagenesis. Okay? So, kung gusto niyo po ma-review yung mga enzymes and yung mga amino acids, maganda po meron kayong mga makikita na mga babasahin dyan. Journal. So, balikan lang natin ha. So, ito nangyayari sa loob ng cytosol at sa loob ng mitochondria. Okay? So, pag na-stimulate mo yung glucagon na yan, it would stimulate ito. Process na to ng urea cycle. Okay? So, itong urea na to ay kailangan natin para mailabas yung ammonia na sobra o yung urea. Now, again, yung activation of your adenyl cyclase would lead to increase your cyclic AMP and your activation of your pKa at again, down the line. Increase ang gluconeogenesis, increase ang glycogenolysis, decrease glycogenesis and glycolysis. Okay? So, very importante itong ureagenesis because ito yung nangyayari kapag sobra ang ating amino acids. Okay? So, makikita natin sa liver ito, di ba? Okay? So, again, this is the glucagon-regulated amino acid. Kaya makikita natin yung liver at saka yung alpha cells very closely interrelated with each other. Now, this is again the liver cells. Okay? So, yung TCA cycle and urea cycle and the activation inside this cell or the mitochondria in the inside the hepatocytes. Okay? So, ano bang importante dito sa progression? Okay? So, kapag normal ang blood sugar natin, yan, mapaprocess mo yung amino acids, and then this would stimulate your glucagon. And then, meron pang mga ibang importanteng hormones like your GLP-1 and your GIP. So, kapag nag-progress or there is progression of insulin, and for some also, there would be insulin resistance and glucagon resistance leading to dysglycemia, this would lead to a diabetic hyperglycemia. So, dadami yung amino acids, pwedeng dadami rin yung glucagon, at yung production of fats would be increased in the liver. Okay? So, dadami yan. Kaya yan yung nakikita natin na fatty liver. So, again, this is one of the mechanism na nagkakaroon tayo ng fatty liver. Okay? So, sabi nga natin, bakit ba may fatty liver yung mga may diabetes? Okay? So, sabi natin, baka this is an insulin resistance, but in part pala, glucagon has a role, okay, in the development of your fatty liver. Okay, so amino acid, again, stimulate your glucagon secretion. So magkakaroon ng hepatic amino acid uptake and urea genesis. So decrease, there will be circulating amino acid concentration, mag-i-increase ang hepatic NADH and NAD ratio. Okay? So in summary, so this is the essential points of your glucagon. So it regulates the amino acid metabolism by increasing urea genesis. Okay? Merong mga amino acid that are powerful to stimulate your glucagon secretion. And glucagon excess causes hypoaminoacidemia, and glucagon deficiency causes hyperaminoacidemia. Okay? So merong feedback loop yan that exists between the liver and the pancreatic alpha cell. So this is the liver and the alpha cell axis of your glucagon. And the disruption of the liver alpha cell axis may cause hyperaminoacidemia and hyperglucagonemia. Okay? So magkakaroon tayo ng problema dyan as indicated by the hypoglycemic effect of your glucagon receptor antagonist. Okay? So we need to understand the molecular mechanism. Kaya I have presented this to you. Okay? So lastly, okay, mabilis na to. Konti na lang, the glucagon and the heart and the kidneys because hindi naman din masyado madaming trial at mostly the trials are being done sa mga laboratory animals. So your glucagon and heart is expressed again in the different organs. Again, wala kasamang muscle. So these are the organ-specific action of your glucagon in the brain, in the pancreas. We have discussed extensively siguro sa liver and the brown adipose tissue and then in the heart. So ang role ng glucagon sa heart is increase heart rate and increase in contractility. So, di ba pagka nag-hypoglycemia, bilgyan mo ng glucagon na stimulate yung heart. So this is, the secretion is regulated by your insulin and your somatostatin. Okay, so alam na natin to that your glucagon secretion will be stimulated by your also by your autonomic nervous systems. Okay, it is also demonstrated that glucagon-like peptide 2 also stimulates your glucagon secretion. So makikita natin uli yung glucagon, and this is the glucagon receptors leading to cascade of events leading to increase in lipid oxidation, leading to insulin sensitivity. Kapag dumami yan, yung toxic lipid metabolites would lead to problem in the cardiac function. So your acute glucagon administration would exert positive action on the cardiovascular performance, either increasing the cardiac index or decreases the peripheral vascular resistance. So sa isang patient na merong non-failing heart, okay, this would lead to rise in the heart rate. Okay, in the failing heart, it increases the heart rate and the cardiac output, together with the dose-dependent increase in the coronary blood flow and oxygen consumption. So your glucagon also facilitates the AV conduction and its inotropic action accompanied by the anti-arrhythmogenic effect. Okay? Following the glucagon administration. Okay? So nag-i-improve yan. So importante din yung glucagon because it has a important effect in the sinoatrial node. So sa SA node. So, yung inotropic agent niya o effect niya, glucagon increases the work of the heart. So again, increase ang heart rate, increase ang contractility of the heart because it increases oxygen consumption, lipolysis, and beta oxidation of the lipids. So, your glucagon receptor antagonism ameliorates the progression of the heart failure. So if you have the glucagon receptor antagonist, it protects your heart. Okay, so by decreasing cardiac hypertrophy, decrease ang fibrotic remodeling, decrease contractile dysfunction. Hindi. Progression of the cardiac pathology. So again, these are the cardiovascular effect of the incretin-based therapy. The therapeutic effect or therapeutic o yung mga medicines would be discussed on the last session. Okay? So pakita ko lang to. Example natin ng incretin-based therapy is your GLP-1, which has a cardiovascular effect on as well dito sa myocardial metabolism. Okay? At ito yung mga nakikita natin. Ito probably the reason why uh, the incretin-based therapies are being used sa mga patients natin na merong heart failure. And these are the mechanism. Okay? So, maganda to maintindihan din natin. Now, in the kidneys, okay, so glucagon in relatively high doses also induces vasodilation. So, nag-i-increase ang renal flow and GFR or glomerular filtration rate and electrolyte excretion. In the kidney, it controls the rate of filtration, urea excretion, and reabsorption of your water through the direct and indirect mechanism. So, the mechanism medyo unclear pa, but you can see, you can review this. So in respect to the electrolytes, the glucagon is also responsible in the increase of natriuresis in the fasting state, and during starvation, it is increased and insulin is decreased. So meron tayong refeeding with carbohydrates which has an anti-natriuretic effect. So there is an initially transient increase plasma potassium level, increase in urinary excretion of calcium, phosphate, and zinc. So ang important role of your glucagon in the kidneys is the excretion of your nitrogen end products. Okay, so again, yung ureagenesis. So very important. So in summary, we have discussed yung regulation of your glucagon in respect to the metabolism of body energy, particularly in the effect on your body fat mass, food intake, and energy expenditure. We have discussed the liver alpha cell axis and the role of your glucagon in the heart and the kidneys. Okay, so speaking of the role of your glucagon, ito yung summary. So with that, I would like to thank you all for your attention. And let's go back to Dr. Marcites. Thank you.
Thank you, Danny, for that extensive lecture, no? Nakakahilo, pero you did it well.
Thank you.
So, clinically, Danny, so immediate yung action ng glucagon pag nagka-hypoglycemia tayo, di ba?
Yes.
What is the reason why we have some patients that we have a intractable hypoglycemia? Ano nangyayari sa glucagon? Bakit may mga pasyente tayo naabot ng 24 hours bago siya magkaroon ng
Bago
ma-correct na?
tumasol yung sugar, di ba?
Oo.
Oh,
Bakit nakakaganon sa mga diabetic?
Oh, kasi in patients with long-standing diabetes, nagkakaroon din ng derangement pala sa glucagon. So hindi lang yung insulin ang may diferensya, pati pala glucagon. So nakita natin yung glucagon, meron siyang mga glucagon resistance. So nagkakaroon din ng mga hyperglucagonemia. So kung madami kang glucagon, so yung iba naman hypoglucagonemia. So pagka konti yung glucagon mo, nag-i-stay yung matagal tumaas yung blood sugar. Diba? So Yung the mechanism involved, wala pa ako masyadong nakita maraming data, pero yung tinitingnan nila more on sa mga studies on rats. So, hindi ko masyado ma-explain. Pero I think there are various mechanism involved. Particularly, kung ang mga pasyente natin na matagal bumalik yung tumaas yung blood sugar because of the hypoglycemia is related also to the mechanism of yung mga drugs natin. Diba kasi matagal silang kumakapit doon sa mga receptors sa insulin. Sa insulin, teka tama. Doon sa receptors ng beta cell. Kaya siguro dahil kapitbahay niya din yung alpha cells, nagkakaroon din niya ng problema. Hindi ko lang ma-explain kung paano. Siguro matulungan tayo. Kung meron po kayong mga nabasa. Pero I think the reason for prolonged hypoglycemia is because of the derangement also in the glucagon. Okay, so tama ba ako, sir? Kuya?
Yeah.
Yes. May protocol tayo para sa sa hypoglycemia. Merong algorithm para ma-pick up mo kung bakit may prolonged intractable hypoglycemia. At isa sa mga ginagawa doon is to check yung C-peptide, pro-insulin at saka insulin assay. Kung minsan merong insulinoma Kaya nagkakaroon ng prolonged hypoglycemia. Gawa ng insulin yung yung tumor. It's a part of a neuroendocrine tumor may kumpletong workup yan. Pag nag-iisip ka ng neuroendocrine tumor naman, ang ginagawa ng iba sa nuclear medicine, hinahanap ko ano yung mga mayroong glucagon receptor o somatostatin receptor. Kaya meron silang mga test dyan ngayon para mahabol kung marami. Kasi kung mayroong insulinoma, nag-hypo yung individual. Meron ding glucagonoma, hyperglycemia naman, intractable hyperglycemia naman. Neuroendocrine tumors. Siguro, magkakaroon tayo isang session on neuroendocrine tumors, presented with either hypo or hyperglycemia.
Pero sa normal individual, kuya, very automatic yung basta nag-hypo ka, ayan na yung glucagon. Yung ba yun? Simultaneous ba yung lahat ng organ
Iya.
ini-stimulate ng glucagon?
Ate, andun sa kanila.
Mag-a-act.
Mami Lola.
Sa normal individual na
Nasabot na ako kay
napapansin
Daddy.
nyo madalas mag-hypoglycemia, no?
Oh, Daddy.
Meron silang explanation doon noon Lalo na yung IGT pa lang. Hindi pa diabetes pero laging nag-hypo. Mukhang mukhang that is the beginning of type 2 diabetes wherein there is beta cell destruction. Kasi every time na ma-stimulate yung beta cell daw, the beta cell, they do not only make insulin, they actually die little by little pagka may hyperglycemia. Kaya imbes na ma-stimulate ang insulin secretion, nagkakaroon ng beta cell lysis. Kaya sumosobrang insulin every time they eat. Pag kumain ng marami, nag-hypoglycemia. Pagkatapos sa 1 taon, 2 taon, wala nang beta cell na na-lyse na lahat. Kaya tumatas na yung blood sugar. Naging diabetic siya talaga, hyperglycemia na. Pero hindi documented yan. That's a theory kung ano nangyayari sa ibang individuals. Kaya pag nakakita kayo ng hypoglycemia after eating, ginagawa ko, huwag niyo papakainin ng marami. O kaya, iwasan niyo yung nag-i-stimulate ng insulin secretion. Alam naman natin kung ano nag-i-stimulate ng insulin secretion. Carbohydrates yun. Pagka nagbigay ka ng maraming carbohydrates, mag-i-stimulate ng insulin secretion yan, bababa ang blood sugar. Pero after a few hours, dahil sa bumaba yung blood sugar, magugutom yung mag-hypoglycemia pagka or gugutom yung pasyente naman Kaya nga sabi nila, the more you eat carbohydrates, the hungrier you become. Tama ba yun, Danny? Kasi insulin nakaka-stimulate ng ano pagkain eh. Hindi kamukha ng glucagon ano. Glucagon nakaka-prevent ng stimulate ng satiety eh.
Danny, muted ka. Danny, hindi ka namin marinig.
Ay, oo nga. Sorry. So, oo nga, sir. Kasi, di ba, yung effect ng glucagon, parang lahat affected, pati yung satiety center sa brain.
Kaya sinasabi nila maganda talaga glucagon eh. Isa yan sa mga nagme-maintain ng ng body weight para hindi tayo nag-gain na masyadong weight. Para ma-break down yung mga yung mga excess stored calories. Kailangan mo talaga ng glucagon. Ang problema pagka sobra na ang glucagon, no? Gawa na ng sugar, sobra ng glucagon.
Yun pala. So, is there any questions sa inyo dyan sa ating chat box? Any uncleared? So, maganda rin from time to time i-open nila para makabisa nila yung mechanism of action.
Review.
Parang very clear out nga na parang ni-review tayo ni Danny na yung insulin, ganito. Yung namang glucagon, ito naman. Parang yung mechanism of actions, talagang nakikita mo yung halos merong involved na potassium and calcium channel blockers on both hormones na that really counteract the action of the other in normal persons. However, in diabetic, may mga nangyayaring kakaiba yung nagiging reactions, 'di ba? Kumbaga sa hormones, nag-excess sila or nagiging deficit sila. Yun ang nagiging problema sa diabetes. Or any question?
Ganda sana.
So, Dr.
Meron magtatanong? May nagtatanong ba?
Nag-congratulate si Dr. Rima kay Danny for a very good lecture.
Congratulations din.
Thanks.
Meron akong idadagdag na tanong kung may darating na na cellular biologist, no? Kasi ang beta cell, no? Kino-close niya yung potassium pump pag mataas ang blood sugar para ma-stimulate ang insulin production. Di ba? Pag ang nag-i-stimulate niyan hyperglycemia. Sa alpha cell, ang nag-i-stimulate ng closure ng potassium pump hypoglycemia naman.
Tama.
On the cellular basis, paano kaya nangyari yun? No? It's the same pump eh. Pero yung isa, ang nag-stimulate ng closure, hyperglycemia. Isa naman, hypoglycemia. Kaya maganda itanong yan sa sa biochemist siguro, no? Sa cellular biochemist. It's the same pump. Pero magkaibang cell, magkaibang response niya.
So let's ask Dr. Nice Bautista. Can I talk with hypoglycemia? Nice?
Yeah, can I talk regarding yung
Of course.
hypoglycemia?
Yes.
Okay, anyway, remember that actually I'll be discussing next week about type 1. No, it's just a prelude to my talk. Remember that as time of the diabetes increases, no, in particular 10 years after, okay, we call that the advanced diabetes. The alpha cell mass doesn't decrease, no. Actually sa mga type 1 nag-hyperplasia pa sila. But the problem is yung tinatawag nilang stimulus secretion coupling. The stimulus secretion coupling is reduced, leading to a loss of the adequate counter regulation, no? And that will produce the life-threatening hypoglycemia. So I'll be discussing about the natural history ng glucagon in my next lecture. Kaya nga yun nga ang matagal yung hypoglycemia. Nawawala yung loss of the adequate counter-regulation.
Mhm. Okay.
So yun yung isang mechanism, 'di ba, yung counter-regulatory hormone, yung mga epinephrine pinapataas niya. Kaya lang nawawala yun. Kaya matagal yung nagkaka-hypoglycemia, marami yung mga this is in particular in type 1.
Siguro
Yun
related
lang.
din
So
yun
it's
sa
about the counter.
hypoglycemic unawareness.
Yes,
Na
related sa hypoglycemia and awareness.
matagal na
Agree.
kasing matagal nang matagal nang may diabetes na laging
Hindi na nila alam na
Yes.
hypoglycemic sila.
Tama po.
Okay.
Thank you.
Thank you, Nay.
Discuss natin next week.
So that is a prelude for our next series of alpha cells with Dr. Nice. Dr. Kailaw, nagsabi siya, thank you and congratulations daw, Danny, for a wonderful lecture. So anything else sa ating how about yung sinasabi mong ammonia, no? The ammonia effect. Nagkakaroon ba talaga ng accumulation ng ammonia? If ever there will be a defect
Oo.
sa
Yung sa metabolism kasi yung ammonia, pagka madami rin amino acids, so mas stimulate mo rin yung glucagon. So pagka marami kang ammonia, di ba, it's harmful to the body. So ang gagawin ng katawan, siguro dadamihan niya yung glucagon para ma-process yung ammonia na ma-excrete through the urea cycle para maging urea siya. So ganun yung ginagawa ng glucagon. So tumutulong talaga siya, hindi lang para magtataas ng sugar, kundi mag-excrete din ng mga waste products. Maganda yun. Kakatuwa. Dikit-dikit kasi sila. Sama-sama yan.
That is related to, can you hear me?
Yes, sir.
Yes.
Yeah,
Yes, sir.
yung kasi ang topic should be beyond glucose control. So beyond glucose control is glucose metabolism. Kasi yung GPCR or G protein coupled reservoir, which is also called 7 transmembrane receptors that is linked to guanine or GPCR, is located in many tissues or target cells. And glucagon is one of the ligands, okay? When we say beyond glucose control or glucose homeostasis, is glucagon effect. Can you hear me? Parang wala yata.
Yes, sir.
Yes.
Yes, it's
sir, we can.
metabolism, okay? The glucagon signaling pathway and the effect on the brain, on the adipose tissues, in the liver, brain, adipose tissues,
heart, kidneys,
heart, kidneys, no? And one of the important things about amino acids and protein metabolism is in the liver. Okay, that is seen in glucagonoma. In glucagonoma, you have a lot of these, dermatitis, no? Magkakaroon sila ng rash, hyperglycemia, magde-depression, etc., etc. And one of the reasons for this is because of the amino acidemia. Tumataas yung amino acids nila. And this it has a relationship between the alpha cells and the liver cells. And during starvation, if you can notice that the liver has to make glucose, right? From the pathway of gluconeogenesis. Saan siya kukuha ng substrate? Sa amino acids. Sa fat. Mauubos din yung fat eh. Di ba? So, kailangan gagawa siya ng magbe-breakdown siya ng protein, proteolysis, dadami ang amino acids kasi gagawin niyang gluconeogenic pathway. Okay? So pag wala yun, pag masyadong marami, ano mangyayari? May breakdown yung protein. Okay? Kaya may relasyon yon, may axis yung alpha saka amino acids. Okay? When let's say if you have glucagon receptor antagonist, you antagonize the receptor, ano mangyayari? Okay? Because of the amino acid, it will stimulate the alpha cell to the alpha cells is stimulated, and then what will happen is the alpha cells develop hyperplasia. Diba? Yan one of the more common side effect of glucagon receptor antagonist, or if you antagonize glucagon. Well, it's good that you can bring down the blood sugar, but the off-target effect is alpha cell hyperplasia. Okay, and you develop hyperaminoacidemia. Maraming amino acid because you don't convert it to urea. It has to glucagon needs the liver needs glucagon for the amino acids to be converted to urea, urogenesis. Wala ba sa lecture mo yon? Yun, sa brain naman, sa satiety. Okay, sa fats naman, it increase the energy expenditure and even increase the mitochondria, the brown adipose tissue. That's why it is combined with GLP-1, glucagon, so that the glucagon effect is for the weight loss, and then the effect of glucagon in terms of the hyperglycemia is balanced by the gut hormones. So it's just a balancing between the two. Because there are agents that has one molecules that binds with the two receptors, unimolecular. One molecule that binds with two receptors. And the receptor, it depends on the tissues. As in GPCR, it depends on the target cells. Okay, now, I just want to respond about the hypoglycemia. Yung hypoglycemia na pinag-uusapan natin is not related to, yun ay tinatawag na over-responsive or responsive hypoglycemia in an early type 2 DM. Pag kumain ng marami, nag-hypoglycemia. Yun ang true hypoglycemia. Okay, tsaka yung sinasabing type 1, yun yung unrecognized hypoglycemia. Mukhang iba din yon, no? Ibang mechanism yon. It is because of the sympathetic. Medyo may problema na sa sympathetic and parasympathetic. If you have autonomic dysfunction, and then you develop hypoglycemia associated autonomic failure. In short, it's called HAAF. So they don't recognize that there is already hypoglycemia, because hypoglycemia initially it's a stepwise. You can have you don't develop neuroglycopenia right away. Sympathetic mo na yan, mga autonomics mo na. Okay. Now, if they develop autonomic dysfunction, then these are removed. So eventually, when they develop hypoglycemia, they don't notice it until they develop neuroglycopenia, and they collapse right away, unconsciously, because they have autonomic dysfunction. Yun. The autonomics, ang unang na-involve dyan is the parasympathetic, because the vagus nerve. Because why? Because vagus nerve is the longest nerve of the autonomics. Okay. Yung kanina sinasabi, post-reactive yun. Okay? Hypoglycemia. It happens. There are several types of hypoglycemia. Okay. Once you have to find out whether it's a true hypoglycemia or a spurious hypoglycemia, or a tumor that causes a lot of high insulin to develop hypoglycemia, insulinoma. Okay.
Okay. Thank you, Dr. Ang, for that enlightening messages for hypoglycemia, no? So with that, Siguro gutom na tayo. With that, I say thank you very much for your for listening and actively participating in our activity. See you on March 20 for the next series of Alpha Cells. Our lecturer will be Dr. Nice Bautista. I say thank you together with Dr. Elwin, Dr. Danny, and Dr. Jamie. And thank you for Warwag too. Good night and
Sure.
keep safe, everyone.
Thank you.